Shortening the short bio.
Yeah, I'm
Please
trying.
just
I
say
am
whatever you want.
really trying. Give
It's
me a
okay.
minute. I don't know.
It's
I don't
not
know
a,
how to do this,
Okay,
but
it's okay,
I am
guys.
really trying.
it's okay. No
It's
worries.
okay, no worries. Okay, it's 3 o'clock in Brazil, 1 o'clock in the US. Hello, everyone, and thank you all for joining us today. On behalf of the Radiology Society of Rio de Janeiro and OCAD, I'm delighted to welcome and thank you all for being here today. My name is Aline Serfati, and I'm honored to co-host this session alongside Dr. Hilary Humans, who has been coordinating and moderating this series with me. Today, we're taking a slightly different approach compared to what we've been doing since the launch of this series in 2021. This special session features two pairs of radiologists and surgeons, Doctors Hilary Humans, Caio Neri, Erin Alea, and Michael Alea. Together, they will provide us with both radiological and clinical surgical perspectives. At the end, we'll have a Q&A session, and if you have questions at any time during the presentation, please put them in the chat box, and at the end, the speakers will respond to them. The presentations today will be recorded and available on demand on the OCAD website, which is ocadmsk.com, and on the YouTube channel of the Radiology Society of Rio de Janeiro. If you want to join the OCAD community and see challenging cases, consider registering on the OCAD website. Hilary has also launched the OCAD LinkedIn, so you can also check out amazing cases in the quizzes and stay updated about the sessions there. Okay, Hilary, please kick off the session.
Okay, I'm very excited to introduce Doctors Erin Alea and Michael Alea. Starting with Erin, she's an associate professor of radiology and orthopedic surgery at New York University Langone Health in New York City, where she also completed her medical school training and musculoskeletal radiology fellowship training. She left Manhattan only for her radiology residency at Montefiore Medical Center in the Bronx. Dr. Alea is active in clinical imaging research and has authored or co-authored more than 50 peer-reviewed publications. She received the prestigious 2022 RSNA Research Seed Grant, exploring the clinical utility of MRI in older patients with atraumatic hip and knee pain. She's an active member and has held leadership positions of numerous national musculoskeletal radiology societies, as well as the ISS. Most recently, she has been inducted. Oh, wait a minute, I lost it. Most recently, she was selected as the AJR Melvin M. Figley Fellow in Radiology Journalism. Michael Alea is professor of orthopedic surgery and sports medicine fellowship director at NYU Langone in New York City. He serves as the president of the NYU Hospital for Joint Disease Alumni Association. He's well known in the field of sports medicine, particularly for complex knee reconstructive, revision, and preservation surgery. He has over 185 peer-reviewed publications and served as editor for multiple textbooks and journals regarding complex knee surgery. He was awarded the Arthroscopy Association of North America Traveling Fellowship in 2017 and has served as a host for several societies and traveling fellowships. His clinical interests lie in multi-ligament injured knee, revision ACL, joint preservation and osteotomies, as well as patellar instability. Okay, take it away.
Hilary, thank you so much for that kind introduction. I'm going to share my screen. You can see my screen?
Yes, but it's not in present. Yeah, now it's in presenter mode.
Okay, great. Hi, everyone. Yes, my name is Erin Alea. Good afternoon. I'm really honored and very much excited to be here today presenting with my favorite orthopedic surgeon. Mike Alea is my husband, but also my colleague. And I can say, as someone who reads his imaging, that he's really just an outstanding, thoughtful surgeon. And he is absolutely a leader in sports surgery.
Hold on, can you say that again so I can tape it? I want to tape that.
As one of my colleagues says, Mike does really hard cases. And I think it's true. So yeah. So this is a great opportunity for us because we've only presented together at NYU conferences. So we're going to be talking about what I think is one of our favorite diagnoses. Okay, so our patient is a 54-year-old female with long-standing knee pain and no significant past medical history. Okay, so this is a video. I'm going to play it slowly. This is a coronal fluid sensitive image. Okay, so we look here, we see there's a tear at the posterior root attachment of the medial meniscus. As we scroll through, I think you'll agree that this cartilage in this patient is relatively pristine. You can see a little bit of meniscal extrusion and really no medial compartment subchondral edema. So here's again showing that posterior root tear of the medial meniscus. A strong advocate, I'm sure many of you are as well. I love the axial images when they're oriented just right. You can really appreciate the morphology of tears and specifically posterior root tears. We can see that this is a complete radial tear. Again, just emphasizing that this patient has perfect cartilage, no edema and mild extrusion. So this is a different patient showing side-by-side coronal MRI and arthroscopic images, again, showing the presence of this posterior root tear on MRI, showing that large fluid-filled cleft in the corresponding arthroscopic image. So here we see an illustration and a different patient, a depiction. Again, I love the axial plane for posterior root tears. This is another complete posterior root tear. Now, posterior root tear is really a diagnosis that stands in isolation. It's something that when I'm forming an impression in my report, it's not just any medial meniscal tear, it's specifically a posterior root tear. And this term is really something that should only be used specifically for patients with radial morphology tears within 1 centimeter of the root attachment or a bone or soft tissue avulsion at the root attachment. I was actually surprised. Recently, we had an SSR Delphi consensus discussion on meniscal tears, and we discussed posterior root tears. And there was some heterogeneity in what people were calling posterior root tears. Mike, what's your opinion on this?
Well, I think I agree with what Bob Laprade published originally in 2014. First off, I want to say thank you to Dr. Rumens and everybody else on the call for inviting us to do this, and thank you to the esteemed other Dr. Alea for nice words that you said about me. Erin is the first call for a lot of the orthopedic surgeons at NYU when they need second opinions on these. Erin has established herself as a quite an impressive radiologist, and she's like the go-to for everybody. So there's my compliment for you. Yeah, I agree with Bob on this, right? It's less than 1 centimeter from the attachment to the root, and it could be either a radial tear or it could be a direct avulsion of the tissue where it attaches. It's important to know that the root that we see on an MRI scan or intra-articularly looking directly at it with a camera is not the entirety of the attachment of the meniscus root or the expansion. About 35% of the meniscus root on the medial side has an expansion that extends posterior to the PCL and attaches actually on the PCL facet, and those are called the shiny white fibers. So the meniscus has 2 attachments in the posterior horn of the medial meniscus, not just to the tibia, but also approaching the PCL facet, and you can see them nicely on arthroscopy. If anybody's interested, I could always get those pictures to you guys, but you really can't see those fibers on an MRI. They're exceptionally thin, and those expansions are almost completely invisible on an MRI scan.
What's the biomechanical importance of those expansions?
Unclear. Unclear, because you never really see a tear of the expansion. Typically, the tear is at the attachment site of the meniscus root. Now, we would think that that helps anchor the meniscus down and potentially prevent extrusion of the meniscus, almost like meniscofemoral ligaments on the lateral side. When you have a root tear of the lateral meniscus, you almost never see extrusion of the meniscus because the other attachment sites of the lateral meniscus, particularly the medial femur, right? So you've got the Humphrey ligament, you've got the Risberg ligament. We hardly ever often see extrusion of the lateral meniscus. So perhaps it's something like that.
Okay. So, going along with what you just said, can you talk to us a little bit about this interesting study coming out of Mayo? Is it the chicken or the egg? Does plastic deformation of the meniscus occur first, or is it tear?
So this was an interesting question, and you and I had discussed this prior to this paper even being published or presented. We didn't know what was first, the extrusion or the tear. And I was hoping to be the first people to publish about this, but my good friend Aaron Critch at Mayo scooped us rather. So they looked at a longitudinal series of patients that had medial knee pain over time. And what they actually found was that the extrusion happens first, right? So the injury to the meniscotibial ligaments tends to happen first, followed by extrusion, and then ultimately tearing of the meniscus medially. And this is what we usually see in patients that are in their 40s to 60s, typically females, typically a little bit on the heavier side. You get that degeneration and breakdown first. This is a joint at risk. Ultimately, the meniscus pooches out sort of like an orange pip kind of through your fingers. If you try to push an orange out of your fingers, it just kind of gets squeezing out. And then ultimately it tears. So the deformation happens first. Often, other times, you might see on patients with medial knee pain, you might see some edema about the attachment site of the medial meniscus root posteriorly. If you see that edema pattern, you have to be very concerned that this is a root tear that's waiting to happen. I've seen it several times in my office where the tear is the last thing to happen.
I think we lost you for a second there, but yeah. And I want to say, I think Hillary published on those findings at the bony findings at the root attachment.
I think it's an oversimplification of the chicken and egg argument, but I think there's actually a heterogeneous group of patients in different pathology, and some are degenerative first and may extrude first. But having practiced in the Bronx, across town from Montefiore, you sometimes see acute traumatic root tears with no previous degeneration. So I think it's more complex than probably what they saw in their patient population. But sorry.
Yeah, I would say that about 95% of our meniscus root tears on the medial side are degenerative in nature, knees at risk. The other root tears that you'll see would either be, like you said, Hillary, in the context of either a PCL or an ACL tear with significant trauma. And those patients you never see extrusion on, those patients you hardly ever see cartilage degeneration because those are isolated injuries. And when you look at long-term results of repairs in those patients, as you would expect, do the best because those are acute traumatic injuries with good blood supply, good vasculature, BMI is usually within normal limits, and the acute traumatic issues tend to do way, way better than the degenerative tears, which is really the impetus of this talk.
Okay. So the patient saw an outside doctor, was indicated for arthroscopic surgery. I'm going to let Mike discuss the arthroscopic images.
So the first image is not shown here. It's basically a meniscus root tear. What you're seeing here is the surgeon went on to do a partial meniscectomy for this patient. So you can see in the back, there's very little meniscus tissue, basically kind of leveraged out the posterior horn tear, which was there, and then contoured it gently all the way to the meniscal body and the anterior horn of the medial meniscus. So this is a partial or even a subtotal meniscectomy after a meniscus root tear. Again, that's poor quality meniscus tissue on the left. This is after the meniscectomy has been performed. Cartilage doesn't look too bad. This picture doesn't tell us much. Lateral compartment's pretty much pristine. You got nice articular cartilage on the top and the bottom. Meniscus looks preserved.
Okay, so Mike, now this patient comes to see you 5 months later. Could you tell us a little bit more about what's going on, what you're thinking?
Yeah, so this patient was referred to us for continued medial sided knee pain after the partial meniscectomy. And the first thing that we're thinking is that this is a knee that might have been in varus, degenerative changes were happening, a knee at risk. And when you take out so much meniscus on a patient that's already in the degenerative process and an at-risk knee, particularly in a patient that's in varus, I have certainly seen many times where these patients develop very rapid onset high-level degenerative changes in the medial compartment. So the first thing on my mind is number one, malalignment. Number two, a knee that is not tolerating a meniscus deficient state.
You ordered the MRI. Okay. So here we have coronal fluid sensitive image. Remember, this is just five months following partial meniscectomy. So remember, this patient had pristine cartilage. Now you can see there's broad, full thickness chondral loss, medial femoral condyle, medial tibial plateau, new subchondral edema-like signal, and I think everyone would agree, just marked meniscal deficiency. We're seeing that root tear again at the posterior root. Again, just showing that broad, full thickness chondral loss, marked meniscal deficiency, subchondral edema-like signal. So Mike, talk to us a little bit more about this study.
So this was a study that, again, my friends at the Mayo Clinic performed. Aaron Critch, Bruce Levy, Mike Stewart. Mayo Clinic has a really wonderful database, longitudinal, of all the patients they've treated for the past 30 years. So this, high-level stuff comes out of there. This was published in AJSM 2020. And they looked at treatment options for medial meniscus posterior root tears. And the patients that underwent medial meniscus root repair, meaning anchoring back down to the bone, to the tibia where it's supposed to be, had substantially less arthritis progression and need for subsequent total joint arthroplasty when compared to partial meniscectomy and non-operative treatment. So they published one at 5 years, they published one at 10 years, looking at either the non-surgical or the partial meniscectomized patients. And those patients did substantially worse than those patients that simply went on to get a meniscus root repair. And the risk of developing arthritis that necessitated arthroplasty was way, way higher in the patients that underwent either non-surgical care or arthroscopic debridement.
Right.
Can I jump in and ask a question about that?
course.
Did they exclude any patients for repair based on degree of existing degenerative arthritis?
No, not in these ones. And typically these patients do have some grade 2 to 3 chondral changes in the medial compartment, Kellgren-Lawrence 2 or 3. We're not really doing these cases for Kellgren-Lawrence 4. Those knees are too far gone. Even Kellgren-Lawrence 3, some people say it's hit or miss, but these are patients that were treated and repaired for good surgical indications.
Yeah. And I think for us, it just emphasizes, how nomenclature matters. This is a specific morphology of tear that is treated, ideally not with partial meniscectomy. Again, images, table or an image from the paper, just sort of showing survival to arthroplasty, and you're really just seeing this patient probably would have done better if they were treated with any kind of arthroscopic surgery, with partial meniscectomy having the lowest survival to arthroplasty.
And it's really interesting, that paper. Those patients that had non-surgical treatment did better than the meniscectomized patients.
Yeah.
So it's an absolute disindication at this point to meniscectomize a root tear.
Yeah. Interesting stuff. So tell us about your thought process now. Here we see the radiographs showing on the left, I would say moderate to severe medial compartment joint space narrowing. Talk to us about standing alignment images, what you're looking for, what you're thinking about.
Well, whenever a patient comes in with a root tear, I always want to know how much varus they're in, because patients that are in significant varus tend to fail meniscus root repairs. So anybody greater than 5 degrees of varus malalignment, I think in the back of my head that patient might be a candidate for a concomitant osteotomy. We're going to realign the bone and fix the meniscus root. Particularly in patients that are failing non-surgical care or failing partial meniscectomy, you have to think that knee is just in varus and the overload, the rapid change in overload in that compartment is not tolerated. So this is a patient that has about maybe 7 degrees of mechanical malalignment here in varus. Anything less than 5 degrees is a great candidate for an isolated meniscus root repair. This patient probably had 6 or 7 degrees of varus prior to this. Now the varus is getting a little bit worse. The meniscus tear obviously had its effect, and now the articular cartilage is completely destroyed. So, I'm thinking here, patient now has 2 options: osteotomy, try and preserve and salvage what's left, or arthroplasty.
Medial compartment, unicompartmental.
I leave that up to the joint replacement guys and gals to discuss whether or not they want to do partial versus total. They have lots of literature that recommend one versus the other in certain situations, but with a relatively pristine patellofemoral compartment and lateral compartment, you could certainly do an isolated unicompartmental arthroplasty. Patients with significant malalignment would much better be treated with a total knee arthroplasty.
In deciding between a high tibial osteotomy and a uni or total knee arthroplasty, in your experience, what would be better for the patient in terms of pain, functional outcome at this stage?
A lot of it depends on their pre-existing activity level and their medical comorbidities. We've got lots of good data that show osteotomies can survive up to 15 years at almost a 75 to 85% rate of success. But we also know that unicompartmental knee arthroplasties can relatively do the same thing. And our data, whether it be randomized trials or meta-analyses or systematic reviews, have really shown that patients that are a little bit more sedentary, a little bit more medical comorbidity, they tend to do better with a unicompartmental knee arthroplasty. Patients that have a very high level of function, meaning high-level recreational athletes, skiers, et cetera, those patients tend to do better with high tibial osteotomy to preserve the joint, because again, we're not really getting rid of the meniscus. We're not really getting rid of the ACL or the PCL. They tend to feel that the knee feels a little bit more normal. But there's no correct answer to that. For me, in my clinical practice, patients that are healthier, younger, more active, we steer towards osteotomy. For patients that are a little bit older, perhaps more sedentary medical comorbidities, we lean towards arthroplasty.
Okay. All right, so here we have an illustration, an arthroscopic image of a patient getting a root repair. Can you talk to us a little bit about this?
Yeah. So the first thing I want to mention, which hasn't been mentioned before, is that the meniscus root injury was really first described from the University of Buffalo, probably about 15, 20 years ago, by Salvo and Les Besson. And they did biomechanical studies looking at the outcomes of meniscus root injuries. And essentially, biomechanically, when the root is avulsed like this, or even if you have a radial tear that goes all the way back to the meniscocapsular junction, that's the biomechanical equivalent of not having a meniscus at all. Complete meniscectomy biomechanically. So that's why these patients tend to do very, very poorly. That's why we repair them, because even with that meniscus still being in the joint, it's not doing a lick of work. So that has really inspired us to do more and more of these cases. Picture on the left is an example of a transtibial meniscus root repair. So essentially, the meniscus has an anchor that goes right into the tibia, very similar to a tree that has roots that anchor to the ground. When I talk to patients, I say that the meniscus also has roots that anchor it to the shin bone. And when the roots are violated, the tree loses its water supply. The tree loses its ability to grow. Same thing with the meniscus, its ability to survive and function. So we want to bring it back down to the bone where it's supposed to be. So you can do this with a suture anchor, but in the recent past, we've developed good techniques to basically drill a hole through the tibia from the front using guides, put a few sutures in the back of the meniscus, and anchor it right back down to the bone. And we could either do this with a suture anchor directly at the surface of the bone, or we could drill a small tunnel and perhaps dunk the meniscus back down into the bone. But the goal here is to use this sort of like a pulley system, right? You're taking the meniscus, bringing it through the knee, through the front of the knee, and you can fix it in the front, basically working as one giant pulley.
We talked a little bit about KL score, the degree of OA that would qualify a patient. What I want to ask you here, Mike, is osteoarthritis versus age. Let's say you have an older patient, even like a 70-year-old or a 60-year-old that has pristine cartilage. Is age going to exclude a patient from getting a root repair?
In my opinion, the answer to that is no. There are some 70-year-old men and women that have a better activity level than I do, right? So why should I get this and they shouldn't? If they're struggling, then they're struggling. I've had some of my best surgical outcomes have been in women in their late 60s and early 70s that have almost pristine articular cartilage and isolated meniscus root repairs. I've had patients run the marathon after these. I've had patients that simply do fantastic when otherwise you're like, you know what, you're 65, maybe just don't treat this, right? Because the outcome we know is going to be worse if we treat this non-surgically. One of my good friend's mothers, she's 73 years old. He sent her to me for a meniscus root repair, and he knew he's an orthopedic sports medicine surgeon. He said, yeah, my mom is 72, but she's very active and she's just not getting better. So we fixed it, and she's doing fantastic. So age is just a number, right? There's chronological age and there's physiologic age. If the physiological age is poor, then yeah, sure, we might want to hold off. But for patients that are very, very active, this has to be in the armamentarium.
Great. And here we see intraoperative immediate post-root repair images, and we have the coronal fluid sensitive postoperative MRI. And I just want to emphasize, because occasionally I'll get a consult from one of my colleagues asking about the signal at the root attachment. We looked at a lot of these patients, and it's very common to see this high signal, this sort of amorphous appearance at the repair site. What I'm really looking at, where my attention is directed, is looking at indicators of functionality of the meniscus. Is it distributing that hoop stress? I'm looking for progression in arthritis. I'm looking for new subchondral edema-like signal, new fracture, any progression in extrusion. Mike, maybe you can talk about this study that was done at NYU.
So this was a really good longitudinal study. We published our outcomes at 2 years, 5 years, and 10 years. All of the papers were in KSSTA, the European Journal of Sports Medicine. So essentially, what we did was we looked at these patients, and at 2 years, there was some radiographic progression of cartilage damage on the MRI. At 5 years, there might have been a little bit more, and at 10 years, there was a little bit more. But the rate of conversion to knee arthroplasty was very, very small. Okay, so that was one thing that we really liked about our papers. The second thing was that meniscal extrusion did tend to progress, although very small. Okay, a lot of extrusion did not happen for these patients. And thirdly, despite any kind of degeneration in the tissues, the survivorship was really good, and patient outcomes and satisfaction scores were actually quite excellent. Excuse me 1 second.
Yeah, so just really emphasizing, even if the MRI does not look good, new edema, progression of OA, these patients in terms of outcomes really do well, very, very well clinically, and it's something that holds up over the long term. So that was our interesting case. Thanks to Mike. It was really fun to collaborate with you. Thank you guys, and please email us if you or ask any questions in the chat.
Go ahead and ask any questions right now, because Michael has surgery. So this would be the time. I have a question, because I know that back in the day, because we published on meniscal root tears actually longer ago than 15 years. And I know that the surgeon I collaborated with would not operate on obese patients. What's your thought on that?
Obesity is probably a small negative prognostic indicator of how these patients do after a meniscus root repair. But again, I've had success on these patients. I mean, you also have to define obesity. I mean, are these morbidly obese patients or patients with a BMI of 30 to 40? Because there's a vast difference between the two of them. It's part of our decision-making algorithm, but it's not the end-all be-all. I mean, if you want to spare these people a knee arthroplasty, then a root repair is certainly a viable option, but you have to do counseling, right? I mean, we've got good weight loss programs, we have good weight loss medications at this point, and there's also bariatric surgery. So, we consult a lot of times on patients that have these questions. You have to have difficult conversations, but you have to do it.
So James Linklater asks, in your clinical experience, do you find ultrasound of value in evaluating root extrusion?
I mean, I might if I was good at ultrasound, but I'm not good at ultrasound. So my answer to that is no. But if you have a very good musculoskeletal ultrasonographer or radiologist who can predictably and reliably tell you how much extrusion there is, then I think it's fine. But either way, you still need an MRI to pick up the meniscus root tear. So an ultrasound can be helpful, probably more for, I guess, research purposes than anything. But I mean, if it's part of the workup in some people's practices, I think it's totally fine.
Yeah,
And
it's not
because-
something that we're doing routinely in our clinical practice. I agree with Mike. I really think the MRI is needed to look at the morphology of the tear, bone marrow edema, OA, any fractures. I would go for MRI.
Aline, the audio.
Sorry. Hi, guys. Thanks for the presentation. I wanted to know, this is from Abdi Dandana. I wanted to know what is the rationale for meniscectomy. I'm a junior radiologist and I wonder why removing the meniscus is a treatment option.
For a meniscus root tear, I don't think that removing the meniscus is an option at this point. We know that partial meniscectomy in root tear patients does worse than non-operative treatment alone. So that's for a root tear. But when you have like a complex degenerative tear, that's a little bit different, right? Those are flaps, those are mechanical issues that are happening inside the knee. So when you remove that mechanical obstruction, it's almost like taking a rock out of somebody's shoe. Once you get the rock out of the shoe, they can walk more comfortably. Same thing holds true for the meniscus. So in the treatment of meniscus root injuries, arthroscopic debridement is really not an option unless it's an irreparable tear, which is extraordinarily rare. I mean, when there's a root tear, that tissue is usually stout. It's usually got good quality. You could easily pass sutures through it and anchor it back to the tibia.
Mike, will you do a root repair in a patient? Let's say they have a root tear and then a body segment horizontal oblique tear. Does that preclude them from getting a root repair?
No, it just depends on what the quality of that tear is and how big the tear is. If you have a tear that's going to extend back to the meniscocapsular junction, let's say at the mid-body, and you have to take that out, then I'm not going to do a root repair because you've already done a partial meniscectomy to the back of the capsule, which again is almost like a functional meniscectomy completely. So, it depends on what kind of tear it is. If it's like a little flap that you're just taking away 10% of meniscal tissue and you've got 8 millimeters of meniscal rim still attached, then a root repair for that patient is certainly in their deck of cards.
Okay. Thank you very much for your excellent presentation. Now it's my great pleasure to introduce thank you very much. To introduce my dear friend, my two dear friends, Dr. Hilary Humans and Caio Neri. Hilary, she's a native New Yorker. She graduated from Amherst College with a major in studio art, and she attended New York Medical College, studied radiology at Jacob Medical Center in the Bronx, and completed fellowship at the Hospital for Special Surgery. She's a professor emerita at Albert Einstein College of Medicine in the Bronx, and is on staff at Lenox Hill Radiology and Imaging Associates in New York City. She's the administrator of the One Case a Day, OCAD, an international online MSK case sharing forum with more than 1,600 subscribers. She's proud to have established the annual OCAD live meeting, created the website, which archives the cases and videos, and recently launched the OCAD LinkedIn page, which highlights educational quiz cases and grows every day. It has been her great pleasure to create this case series now in its 5th year with me as a partnership between OCAD and the Radiology Society of Rio de Janeiro. Hilary is thrilled to be collaborating with her dear friend Caio Neri in this new experiment where we are she and me is planning, we are planning partnering radiologists and surgeons in these case discussions. Caio Neri, he's an orthopedic surgeon who works at the Federal University of São Paulo as an associate professor and at the Hospital Israelita Albert Einstein in São Paulo too. Since the beginning of his career, he has been involved in research and teaching with significant scientific production in the area of foot and ankle surgery, and has led fellowship programs in the specialty, having trained more than 100 specialists who work throughout the country. He was president of the Brazilian Society of Foot and Ankle and the Latin American Society of Foot and Ankle, and has served on the board of directors of the International Federation of Foot and Ankle Societies. He's currently the editor-in-chief of the Journal of Foot and Ankle, a member of the editorial advisory board of Foot and Ankle Clinics, and a member of the medical advisory board of Steps to Walk, a charitable organization that performs foot and ankle surgeries in underprivileged communities in several countries around the world. Please, Hilary and Caio, take it away.
Okay, I'm trying. Remote control. Okay, Caio, you have control of the mouse?
I don't know. Well, let's see.
Let's hope so.
No, I'm not.
It says it's waiting for you to control the screen. Yes.
Yes, yes. Okay. Thank you. It's a great pleasure for me to be here with you today, and I am immensely grateful to Dr. Hilary Humans and Dr. Lynn Sarfati for the invitation. It's really, really interesting for me to participate. We'll take a look at the progressive collapsing foot deformity, formerly the adult-acquired flat foot deformity, and invite you all to help us in the diagnosis of these patients. This is my disclosures. This is a case of a 68-year-old woman who had been suffering from pain and deformities in her right foot for 4 years now. All it started after a wedding party where she danced a little. The next day, she noticed pain and swelling on the medial side of her right foot. She was treated conservatively with a diagnosis of tendinitis and got better for a few days. However, as time goes by, her foot began to fall inwards, and the intense pain prevented her from performing her daily life activities. She was treated for arthritis for a year without any improvement. On physical examination, we notice a medial bulging of the ankle and a drastic reduction of the plantar arch in the right side. Hindfoot valgus and forefoot abductions could also be identified. On palpation, there was intense pain along the course of the posterior tibial tendon and the medial face of the foot. All the deformities were flexible and reducible. In the weight-bearing plane radiographs, one can identify the subluxation of the talonavicular joint in both AP and lateral views, followed by the collapse of the medial arch. In the axial view, we can identify the increasing of the moment arm of the right calcaneus, confirming the hindfoot valgus deformity and the medial bulging of the soft tissues. In the AP weight-bearing radiograph of the ankles, we can note an increase in the medial clear space, suggesting insufficiency of the medial stabilizer on the right ankle. Let's take a moment and look at the evolution of our knowledge in this condition. The first reference to this pathology was made by Kenneth Johnson, who described the condition in 1983 and attributed the deformities to the rupture of the posterior tibial tendon alone. Although the posterior tibial tendon is still one of the main actors of this complex deformities, there has been a significant change in our understanding of the pathophysiology of this condition. Recent anatomical studies have identified an enormous complexity of ligamental tracts in the interconnect and interact to form the deltoid and the spring ligaments, each one playing an important role in the medial stabilization of the foot and ankle. Understanding these interactions is paramount to improve the diagnosis and treatment of numerous conditions affecting this anatomical region. The spring ligament functions as a support for the talar head and plays a key role in stabilizing the mid-tarsal joints and the plantar bolt. The talocalcaneal interosseous ligament, which is still so poorly understood, are responsible for stabilizing the subtalar joint, maintaining the relationship between the hind foot and the ground below and with the ankle above. The dynamic stabilizers represented by the different tendons highlighted here complete the network responsible for the perfect balance of the stability of the foot and ankle as a functional unit. Today, we believe that the chain of the pathological event can begin in any of the main stabilizers, causing the overload and failure of the others over time. From this point on, it becomes easier to understand and justify the osteoarticular involvement and progressive collapse of the foot observed clinically. Each stabilizing agent can be correlated with the generation of a specific deformity, as well as influence in the other deformities, as we can see in this diagram. This understanding is vital for the treatment decision making. Now, I would like to invite Dr. Hillary to enlighten us about the imaging diagnosis of progressive collapsing foot deformity. Hillary.
Thank you, Kaio. So in order to understand what goes wrong in this patient, I just want to make sure that we all are familiar with the normal anatomy as we include some trainees in the group. So from medial to lateral in the flexor compartment, we have the posterior tibial tendon, flexor digitorum longus, the neurovascular bundle, and the flexor hallucis longus. Now, scrolling anteriorly, the posterior tibial tendon will be indicated by the yellow arrow, and the deltoid and spring ligament complex will be indicated in blue. So at this point, we're still looking at the part of the deep deltoid, and we're getting into the superficial anterior deltoid ligament. The posterior tibial tendon is staying medial to the ligaments. And now we're at the tibiospring ligament that's going to blend with the superior medial spring ligament at this point. Okay. In the oblique axial, you can see the plane of imaging in the upper corner. We're looking at the deep deltoid ligament and the posterior tibial tendon superficial to that. And now we're moving into the anterior components of the superficial deltoid, and that's going to blend with the spring ligament complex. And notice that the posterior tibial tendon always remains superficial to the ligaments, and the main portion inserts onto the medial pole navicular. So I'm going to highlight the posterior tibial tendon, which is normal in this example. And you can see the broad insertion onto the medial pole navicular. In this person, even though it's a non-weight bearing exam, I look at the alignment between the long axis of the talus and ideally what will become the long axis of the first metatarsal, and it seems to be aligned, implying that the arch is preserved. Then we look for the spring ligament, and the spring ligament should live in between the deep surface of the posterior tibial tendon and the talar head. So as Kaio said, the spring ligament has three components: the superior medial, the medial plantar oblique, and the inferior plantar longitudinal. Here we're looking at the medial plantar oblique, the inferior plantar longitudinal, and the superior medial component. He also mentioned the importance of the talocalcaneal interosseous ligament, and this is something that we haven't routinely looked at on MRI, but I'm making an attempt to do that ever since I've collaborated with Kaio on this project. So now we're looking at images from Kaio's patient, and I want to point out that even though clinically we could see that her arch was collapsing as she bore weight and walked, and the weight-bearing radiograph showed that her arch was collapsing, the alignment seems to be relatively preserved in this non-weight-bearing examination. That's a limitation of non-weight-bearing MRI. Also, I want to point out that we see in this case preserved fat planes in the sinus tarsi, because surprisingly she doesn't have much reactive soft tissue inflammation in the sinus tarsi. Now we're looking at sagittal plane images, which is in plane with the the posterior tibial tendon, not ideal, but we can see the thickening and some increased intrasubstance signal and fraying of the proximal and distal segment of the tendon. And at the level of the medial malleolus, there's certainly some intrasubstance tearing, so it seems, in the sagittal plane. The axial plane implies a much higher grade tear. So here we see the thickened posterior tibial tendon. It looks like there's a split type tear. There's tenosynovitis. As we progress more distally, we see that there's not only the split tear, but the tendon is looking thinner altogether. And to me, it looks like we're getting into a very high grade partial tear at this point. The posterior fibers of the deep deltoid ligament are a little bit frayed and distorted. Here we see at the level of the talar dome a very high-grade tear of the posterior tibial tendon. And we're getting into the anterior portion of the superficial deltoid ligament, which is frayed and degenerated. And the supermedial spring ligament is thickened and frayed, and there's increased intrasubstance signal. And I imagine at this point, at the confluence of the tibial spring and the supermedial spring ligament, there might be a full thickness tear. Beyond that segment in the posterior hindfoot where the tendon looked so thin and really honestly fragmented, the distal segment looks relatively thick. So, I would wonder if this, were functionally a complete tear. And then we get into the most distal segment, and the tendon is quite thick with intrasubstance signal, but no tear at the insertion. In the coronal plane, we're seeing the same thing. That's the superficial part of the deep deltoid ligament. And then we're starting to get into the anterior superficial deltoid, which is thick and frayed. And the superior medial spring ligament. And I think right here, remember, you should have spring ligament between posterior tibial tendon and the talar head. I think maybe there's a wisp. It looks to me like there's probably a full thickness tear of the superior medial spring ligament at that site. And now we're into the posterior tibial insertion. Okay, and just a couple of pertinent negatives. We don't see reactive edema or cyst-like changes on both sides of the sinus tarsi, which would be signs of sinus tarsi impingement. I don't know that this is the best image. There was another image. I didn't think there was compelling evidence of subfibular impingement. Okay, I'm going to hand the cursor off to Dr. Neary to describe the surgical treatment.
Wonderful, wonderful. Thank you very much, Hilary, because it was very instructive, and I think that we have to plan our treatment based on your findings. Fortunately, I have had the help of our colleagues here in Brazil, so we have almost the same vision. So, and our first step is to stage each patient according to the flexibility or rigidity of their deformities. In this particular patient, all the deformities was flexible. And after that, we classified based on the presence of the clinical findings as hindfoot valgus, talonavicular subluxation, medial column instability, reduction of the plantar vault, and ankle involvement. As we can see in this new classification system proposed by a group of experts in 2019. Our patient was classified as stage 1, classes A, B, and C. All right, what it means? That means that we have plenty of procedures available in our armamentarium to deal with this kind of patients. Among this, the surgical resources available, we have bone procedures such as osteotomies, isolated or combined arthrodesis. Then let me change this. I have to come here. Where's my here? Okay, so the bone procedures such as osteotomies and arthrodesis combined or not, and soft tissue procedures, mainly the ligament repairs and tendon transfers. And all these techniques can be combined to increase the efficiency of the treatment that aims, in short, to restore the functional stability of the foot and ankle. We usually start with a medial calcaneal sliding osteotomy to correct the hindfoot valgus. And we fix it with 2 screws very, very often. And through a wide medial access, we identify the posterior tibial tendon and its pathological changes. Most of them was predicted by the MRI images. Now we delimit the injury of the spring and deltoid ligaments here, and the flexor digitalis longus tendon is isolated and prepared to be transferred to the navicular bone, assuming the function of the posterior tib that was torn. Fiber tape anchors are implanted in the footprints of the injured ligaments, serving as augmentation to those repairs that will be performed in the ligament substances. The repair construct is then tensioned and fixed to restore the local anatomy. Basically, we are trying to restore each portion of the spring ligament and deltoid ligament that we found torn in the MRI. Before finishing, the tibial tendon is sutured to the transferred FDL to maintain its mechanical and proprioceptive functions. Additional sutures complete the reefing of the soft tissues of this region. The patient is kept in non-weight bearing boot for 6 weeks, followed by a rehabilitation program of the same duration. This is the clinical appearance of the patient 8 months after the surgery. She reports substantial improvement on her functional pattern, having reassumed all her previous activities. Here, we can see the posterior view of both feet, and here, the tip-toe position. Regularly, a slight residual edema persists till the end of the first year post-operative, but most of the times we recover the plantar vault and the right position of the foot. The anatomic relationship of the patelonavicular joint was restored in both the AP and the lateral views, and the calcaneal moment arm was normalized in the axial view. At 2 years of post-operative assessment, patient considered her result to be excellent. The surgical scars evolved satisfactorily and was not cause of any complaints. The calcaneal screws that caused slight discomfort when walking barefoot were removed in this patient. The bone correlations obtained show to be very stable in routine plane radiograph evaluation in all planes. At the end of 5 years of follow-up, the patient was released to lead a life without any restrictions, and we stopped following her till she had new complaining about this foot. This is our case, and I thank you very much for the opportunity, and we are at your disposal to clarify any remaining doubts.
Thank you, thank you. Are there any questions?
I don't see, oh, I see one now. Oh, no, just saying amazing, thank you.
So Kyle, you said that that at surgery the tendon didn't seem to be the posterior tibial tendon didn't just seem to be as torn as it did on the MRI.
Yes. Sometimes it's very frequent that we see a very strong scar tissue involved with the tendon. So if you don't pay attention, don't pop it, don't feel in your fingers the rigidity inside the tendon. Many times you think that the tendon is okay, but it's not. There are kind of destruction of the fibers inside that scar tissue. So you don't have to leave it alone. You have to open it to see inside the tendon if there are some nodules or torn tissue for you to clean everything and substitute or solidarize this tendon with the flexor digitalis longus. That was really very frequently used as a substitute.
So we look to characterize the lesions and extent of the lesions of the posterior tibial tendon. We look at the integrity of the mostly the anterior superficial deltoid and the spring ligament, especially the supermedial spring ligament. But let's say, I mean, oftentimes the posterior tibial tendon is really just degenerative and may or may not even have some interstitial tearing. Will you still do the flexor digitorum longus transfer in those cases?
Yes, all no matter if I find a very gross destruction of the tibial tendon, posterior tibial tendon, I used to do something to improve or to augment his potential of function. So sometimes we have a side-to-side combination of the flexor digitalis longus with the posterior tip. But very often I do the transfer of the flexor digitalis longus to the navicular bone through a bone tunnel, and I use kind of a interference screw to fix it there in a very strong manner, so that it can assume part of the function of the posterior tip very fast.
Kate Stevens is asking if we routinely use the oblique axial images instead of straight coronals. Actually, both are part of our routine protocol. They're complementary. This is particularly helpful, for many of the tendons dealing with magic angle artifact, and it optimizes, visualization of the CFL. And, the images are so much faster now. It's not a big commitment. So James Linklater is asking, do you think there was chronic posterior tibial tendinosis and the minor trauma caused the spring ligament rupture? What's the
I
role?
think
And he also asks, what's the role of arthroeresis screw in such cases? And what's the management of isolated spring ligament rupture?
Oh, so we saw very rarely the isolated lesion of the spring ligament. I have plenty of cases, but they are very active, very aggressive, sportive guys that have a kind of a trauma or aversion or a fall from a height. So I think that it's very rare to see the only the spring ligament. But I used to repair it. It's the repair is not that complicated that just like in the progressive collapsing foot deformity, but we have plenty of cases of correction of that. And in this complex of deformity, named the progressive collapsing foot deformity, I think that we don't know who is the first structure to fail, but one will call the other to action, and well, I think that in a few times all those structures will be involved because they try to compensate. They try to get the function or to stabilize it, no matter what the joints at this moment. So it's very frequent now. We find people with deltoid ligament destruction and combined with spring ligament and really good tibial posterior tendon. So that's what made changes in our way of thinking, because how to deal with the old classification systems or pathologic mindset if we don't see that the posterior tibial tendon involved. So this findings make us change a little our way to see the pathology. Now it's
James
wide.
also asks, sorry, James also asks, when do you consider lateral column lengthening or DFC1 osteotomy?
It's a very good question, because lateral column lengthening is a very uncomfortable surgery to do, and there are so many criticism on that, because it's a very difficult to balance the rear foot and the mid foot only with this surgery. So the best experts in the world, they are trying to substitute this lateral lengthening column by other type of combinations of surgery. In my practice, I use very rarely. I have to have very aggressive deformities with abduction, very bad abduction, and there are some questions very difficult to solve. For instance, it will be accepted subluxation of this calcaneocuboid joint. Do you have to stabilize this? How to do with when the things are kind of hyper pressing the calcaneocuboid articulation, and pain comes down from it. So it's very difficult to balance that. So in my practice, I am giving up to use that.
And
And I think
I have
that
a very
people.
practical clinical question from my friend Volker Lipsinski, who asks, what are the main and hard criteria for switching from conservative to operative treatment? Do you wait, or is it better to stop the process early?
I think that the earliest the best. So I think that one of the things that we teach our residents, our fellows, is that don't trust that there is tendonitis of the tibial posterior tendon. There's there's such a thing. I think that it's the first stage that Kenneth Johnson have mentioned, the inflammatory phase, but it would not stop there. In a few years, 2 or 3 years, this tendon will fail, and after that, it's so late for you to pay attention to the deltoid and the spring ligament. So you have a combination of lesions at that time. So more than often, we try to call the attention of our residents to the posterior tibial tendon. It's tendonitis. I don't believe that. I think that it's the first stage of the old classification of the progressive collapsing foot deformity.
Okay, we're out of
Great.
questions, Selene.
Yes, thank you all for joining us today. Our next session is scheduled for March 14th. Mark your calendars, and we'll see you then. Thank you very much.
Thank you.
Thanks, Aline. Bye-bye. Bye-bye, everybody. Thank you for having us.